Good afternoon, everyone. I'm coming to you live to talk about pre-implantation genetic testing today. So this is a common thing that we talk about day in and day out within the practice, and there are always lots of questions. And so I thought that just doing a little basic review of what pre-implantation genetic testing is, as well as answering any questions that you guys might have about the process or the pluses and minuses of it, I'm happy to answer. And so first and foremost, pre-implantation genetic testing is something that is available to our patients that are doing in vitro fertilization. All right, and so this is something that we do when we are checking the chromosomal status or genetic makeup of an embryo prior to putting it back into the mother's uterus. And so the first step is obviously when a couple comes to see us, we always do a thorough fertility evaluation with the couple. And then once it is determined that they need IVF, then the discussion of whether or not they want to biopsy embryos and do genetic testing is discussed in their treatment plan. So when a couple undergoes IVF, there are a few different reasons why they would elect to genetically test embryos. The first most common reason that couples elect to test embryos is to make sure that it is chromosomally normal or euploid. Okay, and so what we're looking at in that scenario is the embryologist, when they biopsy the embryos, they're looking to see if the whole chromosomes are normal for the embryos. Other things that pre-implantation genetic testing can test for is in the workup phase for different couples, if you're found to be carriers for a specific genetic condition, or if you come to us knowing that you're a carrier for a specific genetic condition, then there is a way for us to build a probe against that genetic condition and then test the embryos to make sure that they're not affected by it. So I'll go into a little bit more detail of kind of how that works and answer any questions that you guys have then, okay? And so first and foremost, the couple undergoes IVF, and so I think we've covered IVF stim cycles in a previous Instagram, so I'm not going to go through all the nuts and bolts of an IVF cycle, but the gist is the couples undergo an IVF stimulation where the woman is taking hormonal injections for 10 to 12 days, and then once the follicles are retrieved, the eggs are then fertilized with sperm, whether it's partner sperm or donor sperm, and the embryos are then allowed to grow within the lab for 5 to 6 days. And why is it 5 to 6 days? What is magical about that time period? And so the embryo goes through different developmental stages after fertilization, and it's not until day 5 that it reaches a stage called a blastocyst. In a blastocyst, the embryo has different parts to it. It's no longer just a few cells. It develops cells around the outside called the trophectoderm, which those cells will become the placenta eventually. And then there's a ball of cells in the middle of the embryo called the inner cell mass, and that's eventually what will become the baby. And so what the embryologists are able to do once they have a blastocyst is, if it's of good quality, they're able to biopsy the cells that become the placenta, so the trophectoderm cells. And what happens is they do a biopsy and then they freeze the embryos. There are some centers within the United States that have the capability of doing PGT-A or PGT for aneuploidy at the time and still doing a fresh transfer, but that's not an option here. And so because we use a laboratory outside of our own to do the genetic testing. And so what happens is the embryos are biopsied and then they're frozen, and then the cells that we take from the outside of the embryo are then sent off to a genetics laboratory. What happens then is once the laboratory receives the cells, they take the cells and they basically isolate the DNA, and then through a scientific process they amplify the DNA, because you're talking about a few cells and you need millions of copies of the genes to determine if it's normal or not. And so they amplify the DNA, and then depending on the reason for which you're doing pre-implantation genetic testing, they run a test to then look at the genetics of the embryo. And so for PGTA, which is pre-implantation genetic testing for aneuploidy or chromosome abnormalities, they're looking at whole chromosomes. And so that is by far the most common reason patients do genetic testing, because they want to rule out that they're transferring an aneuploid or chromosomally abnormal embryo. The reason to do that is that it increases your chance of pregnancy if you're of advanced maternal age, to know that you're not transferring a chromosomally normal or abnormal embryo, and also it decreases your chance of miscarriage. In addition to that, like I mentioned before, there are some couples that are found during our workup phase to both be a carrier of the same genetic condition. And so every couple that comes through the practice, and most reproductive endocrinologists nationwide do this, where they screen couples through something called expanded carrier screening. And what that is it's looking at a bunch of genes that you can carry that you're not affected by, but the baby, if it inherits 2 bad copies of that gene, can be affected by. And so if you and your partner are both found to be a carrier for the same genetic condition, then in the case of recessive conditions, 25% of your embryos can be affected. And so if you're going through the whole process of doing IVF and extracting eggs and making embryos, if you're known to carry one of these conditions, most couples will elect to then genetically test for that condition. PGTM, which is pre-implantation genetic testing for monogenetic diseases. That's a mouthful, but basically it's specifically testing for a specific disease or disorder that you're a carrier of, is a bit different than doing just straight PGTA, which is looking at whole chromosomes. And the reason for that is that the laboratory has to build a probe against what your specific genetic mutation is. And so prior to doing your IVF cycle, if you're going to do genetic testing for a specific genetic disorder, you undergo a preparation phase where we'll draw DNA samples from you and send it off to the lab along with your genetic results. And the lab will build a probe against the specific genetic disorder that you have. And then from there, once that probe is built, the process for you looks identical from the standpoint of you undergo the IVF stimulation, you have the retrieval, we make the embryos, and the lab biopsies the embryos. The difference being on the flip side, when the cells go to the genetics laboratory, they do a different preparation of the DNA that's more in depth and to look at that specific mutation, okay? All couples that undergo PGTM for a genetic disorder also have PGTA performed, because if you're going through the process of identifying embryos, say, without cystic fibrosis, you also want to make sure that it's chromosomally normal before you put it back, okay? And then the third thing that PGT is sometimes used for is for patients that have something called a balanced translocation or translocation. And so what happens is sometimes you have all of your genetic material, but they can be located on different chromosomes than they're supposed to be. And that's not a problem for you, but when you go to create offspring, your genetics don't exactly fall out the same way for your offspring as they do for you. And so some of the embryos can have missing chromosomes or extra chromosomes based on these structural rearrangements. And so PGT-SR is looking at specific translocations to make sure that the embryo has a complete complement and normal makeup of their genetics. And so I'm just looking, sorry, I got a question. And so that's the basics of pre-implantation genetic testing. I'm gonna try and answer the questions as they come. Again, I'm not the Instagram live queen, so it takes me a minute, but Vanessa asked a question: what are the chances that negative result embryos fix themselves to become normal days after? So that's a great question, Vanessa, and that leads to a lot of the controversy and debate over PGT. And so it's an excellent question. And so when we genetically test embryos, what we're testing is the cells on the outside of the embryo that become the placenta. And you're taking 5, maybe 10 cells at most out of hundreds of thousands of cells, right? And so when you take these 5 or 10 cells, there's a sample of the cells. And so we feel fairly confident that that sample of cells is a good representation of the embryo, but it's not perfect. So PGT, sometimes you can call an embryo aneuploid or abnormal that could possibly have been normal and you just got cells that were abnormal, because there's a process of something called mosaicism, where I explain it to my couples as think of like a soccer ball, so that the cells on the outside of the embryo can look like a soccer ball. Most of the embryo is white or chromosomally normal, and then you have every few that are a different color, and then that different color one could be a chromosomally abnormal. And what happens in natural selection is hopefully the good cells propagate and the bad cells don't. But when they do the genetic testing of the embryo, they amplify the DNA, and then when they get the readout, they look for a certain level of abnormal. And so if more than 30% of the embryo is abnormal, then they call it abnormal. If 10% is, then they might call it something like a low-level mosaicism. And so it depends. So PGT, although good, is not perfect. And so that's definitely a conversation that you should have one-on-one with your reproductive endocrinologist about what those risks are to you. For some couples, based on their age, maternal age especially, doing PGT doesn't necessarily change their outcome, because say you're less than 35, most of your embryos should be chromosomally normal, 60% of them, right? And so it doesn't necessarily help to do PGT, except for the fact that you know what you're putting back is chromosomally normal. It's less likely to call something normal that is abnormal, more likely that PGT would say something is abnormal that could possibly be normal. That being said, we don't transfer chromosomally abnormal embryos within our center. It's an area of hot research and intense debate among reproductive endocrinology community as well as geneticists. And so it's something that's constantly being evaluated. But in short, that's kind of my answer to, can embryos self-correct? Let me see if there are any other questions. All right, so I don't see any other questions. Other things that are important to know about for PGT is, say you have a family history of a disorder that runs in your family, like cancer, right? There are certain genetic reasons for people to get cancer, such as BRCA. So if you were found to be a BRCA carrier, or have a family member that's a BRCA carrier, or an extensive family history of having multiple family members with breast cancer or colon cancer, ovarian cancer, things like that, then it might be prudent to be tested to see if you're a carrier for one of these genetic conditions, because there is a way through PGTM where we can build a probe if you're found to be a carrier of these things and eradicate that from your family's genetic pool. And so that's something that is very good to know is available. It's not just for BRCA. There are tons of different oncogenes that are available for screening at this point. And so it's something that if you have multiple family members affected by cancer, that you should absolutely talk to your primary GYN or your reproductive endocrinologist and see if being referred to a genetic counselor is appropriate for you. All right, let me see. So then there's a question about, does embryo testing provide insight to issues like Down syndrome, for example? Yes, so for example, that's a great question. So the PGTA is looking at whole chromosome abnormalities, which Down syndrome is one of those things, right? So Down syndrome is where you have 3 copies of chromosome 21. And so that is something that can be detected by the implantation testing. There are other disorders like, say, autism, that you cannot test with genetic testing unless there is a known genetic underlying cause, like something like Fragile X. But for chromosomal abnormalities, so trisomy 13, trisomy 18, trisomy 21, Down syndrome, and the sex chromosome abnormalities being the most common, those disorders, those are absolutely screened through preimplantation genetic testing. Let me see if there's any other questions. What about ERA testing? Is that recommended prior to transfer? So ERA is a completely separate topic from preimplantation genetic testing, but it is something that is available to couples. You'll find varying opinions on its efficacy and strength of recommendations of doing so. But ERA, what that is it's an endometrial receptivity assay, and it's something to consider if you have a lone embryo, meaning you only have one embryo and you're wanting to optimize your chances of pregnancy. Sometimes reproductive endocrinologists will undergo this test, or will have their patients undergo this test where they get prepared for a frozen embryo transfer, but instead of doing the transfer, they end up getting their lining biopsy to see if it's receptive for implantation. And if not, if more or less progesterone is needed for timing of the transfer. And so that's something that generally is not a first line step for me in my practice, but I do have colleagues around the country that if you have one single embryo, even before you've ever had a transfer, will go to that test. It varies between doctors what the opinion is, but that's kind of what ERA testing is. Let me see if there are any other questions. So that's pretty much what I have for preimplantation genetic testing. It's not, unless you guys have specific questions about that, I'm happy to answer any other questions that you guys have about different topics at this time. And then also I wanted to just wish all of our LGBTQ community happy Pride Month, because it is June, and so I would be remiss if I didn't say something about that. So if you choose to do embryo testing, you won't be able to do a fresh transfer. That's correct. So if you do genetic testing of the embryo, because we use a laboratory outside of our actual practice, we have to freeze the embryos and send the genetic samples away to be tested. And by the time we get those results, your lining is out of sync for a transfer. And so generally the very next month is when you undergo the transfer. So it is a delay of about a month between when you would have transferred normally if you didn't do any genetic testing and what you would do with genetic testing. However, I will tell you that even in the cases of patients that aren't undergoing genetic testing, it's still common to do something called a freeze-all cycle, because sometimes the are less than ideal and your chances for pregnancy would be better on a subsequent cycle. So say somebody has like an IVF stimulation and had a robust response. Sometimes we elect to just freeze the embryos, even if they're not doing the genetic testing, because their risk of something like ovarian hyperstimulation is so high that we want to prevent that from happening. And so yes and no, it does delay it by about 4 weeks, but you may have been delayed anyway if you had a robust response. So plus minus on that, and the pregnancy rates are very good from frozen embryo transfers. What happens with abnormal result embryos? So that's a great question. So when we get the results to your genetic testing of your embryos, we have an in-person consultation where we go through each of those embryos. It is up to your discretion as to what you want done with the embryos. We do not transfer abnormal or mosaic embryos within our practice at this time. But if you elected to want to keep your embryos because you just wanted to keep them and you'd want to transfer them somewhere that would transfer an abnormal embryo, then we can absolutely do that. We don't discard any embryos without talking with our patients. Okay, they're precious. We understand that, and that's something that we would never do. But that being said, we don't keep abnormal embryos for transfer routinely. Let me see, any other questions? And, you know, when talking with your doctor, it's important to understand what your chances of chromosome abnormalities are based on your own age, right? So the discussion that I would have with somebody that is 30 with tubal factor infertility is different than the discussion that I have with somebody at 42, also with tubal factor infertility, right? Just because age also has a factor in your success rates and your risk of aneuploidy or chromosome abnormalities. And so as we age, we're more likely to have chromosome abnormalities happen in our offspring, and it's important for us to know, you know, what those risks entail, because you may be able to become pregnant with a chromosomally abnormal pregnancy, but the most likely case is that either it would not implant, or if it did implant, you would have an early miscarriage. And having a delay of having a miscarriage, then having to deal with that miscarriage, have your body recover, and then undergo either another stimulation to obtain more embryos and or a transfer because you had another embryo to transfer, you know, it's a delay in time. And when you're of advanced maternal age, time is important because our fertility declines over time. And so that's something that definitely needs to be weighed into the decision. And so I'm in the camp of not everybody needs PGT, but we discuss it. And if it makes sense for you and your family and what your goals are, then we absolutely will pursue it. Any other questions from the galley? Let me see. So I think that's it for questions. If anybody has any others, I'm happy to field them. If not, then I think that'll be it for me for this Instagram Live. If there's any topics that you want to discuss, I'm happy to put together a little topic so that everybody gets their questions answered. If you don't feel comfortable asking a live question, feel free to message us either through Instagram or through our Facebook account, and we'll get back to you one way or another. But thanks, guys. It was so nice to do this, and I hope you learned something, and I look forward to seeing you guys soon. So have a great day.